We're here for episode 2 of the Sleep App podcast, and I've got with me today Dr. Linda Schachter. Linda has been a sleep and respiratory physician for 24 years with an interest in the diagnosis and treatment of all sleep disorders, obesity and workplace fatigue. Linda has a long-term research interest in the effects of obesity on sleep apnea, lung function and asthma, and the effects of weight loss on these conditions. She's also been involved in setting up sleep studies and sleep screening in the home. She is a member of the Thoracic Society of Australia and New Zealand, Australasian Sleep Association, American Sleep Association, American Thoracic Society, the Obesity Society of Australia and New Zealand, the Australian Medical Association, and a clinical committee member of the Australian Sleep Association. Thanks for joining us today, Linda.
Thanks, Phil.
So we'll jump into the questions. We've got 2 sections today. We're going to go a bit of Q&A, and then we'll hear from you presenting on obstructive sleep apnea and an approach to diagnosis a little bit later. The first question I had for you today was, as a part of the ASA Clinical Committee, we want to chat a little bit about the coronavirus, and I guess my question is, what do we know about how it affects patients suffering from OSA?
So at this point, we actually don't know very much. However, looking at some of the information that we can gain is where there could be potential risks for people who've got sleep apnea. First of all, I suppose we'll go through treatment. So if you're on CPAP and you've got sleep apnea at this time, what should you do?
Yep.
I'm going to divide it into 2 different groups, if that's okay. One is if you're got suspected coronavirus or COVID-19, and one if you don't. So first of all is, what are the risks of continuing CPAP therapy at this time if you're not at risk of coronavirus? So if you're not at risk of coronavirus and you're not unwell, the risk or the thought is that what CPAP may do is aerosolize viral particles, if you have any. So this is actually where the concern is. There's an exhalation port on the mask. So basically, so you can breathe out and you don't actually get that your carbon dioxide level goes up. You've got to be able to breathe out. So that's really what the concern is, that maybe through this exhalation port and through CPAP, that we're disseminating more viral particles into the environment. Now, if you don't have COVID-19, that's no increased risk. If there is a concern that you do have COVID-19 or coronavirus, the concern is that you may be dispelling or pushing more viral particles out into the environment. Then the big question becomes, what happens to, and the risk predominantly is to the people around you. Now, if you're in the home environment, it's to your partner and other people who are at home. So they're what the concerns are. Now, the other concern is, if you stop CPAP, what are the risks of that? Now, short term, it can be the symptoms that you had that you originally went on treatment for. So it may be that you're sleepy, it may be that you've got an increased risk of falls, or it may be that the effect on your heart, blood pressure, and other effects of sleep apnea. So I suppose with all of these things at the moment, it's a risk-benefit analysis with each person. And if people aren't sure what to do, it's probably a really good idea that they talk to their doctor about it. If you're in hospital and with suspected COVID-19 and you're on CPAP, it is important to take your CPAP with you. What may happen is that the concern is that, and we really don't know whether CPAP actually could make the virus worse if you've got it. And that's nobody knows that at the moment. But then the balance is that if your airway collapses during sleep and you get a chest infection, you're at a higher risk of other complications from the sleep apnea. And which again, we don't know whether COVID-19 actually makes those worse. So do take it with you. You may be put on a different mask. You may be put in a special room to make sure that limit the viral transmission. But at this stage, it's going to be on an assessment on a person-by-person basis.
Okay, fantastic. So what you're saying is a patient that is on CPAP, if they, unfortunately have to be admitted to hospital, taking CPAP with is important. And by the sounds of things, your bed partner's at risk of infection if you're infected, and that's probably true for most cases, but maybe at a heightened risk with somebody on CPAP. What is there any other tips and pieces of advice for those CPAP patients that they should be considering in the home? Moving to a separate room, things like that, obviously, are helpful. If a patient has to go off CPAP, what would your recommendation there be, and what would we have to look at?
If somebody has to go off CPAP, if they have symptoms of being tired or sleepy, maybe they don't drive over this period of time. So if that's one of their symptoms, maybe they don't drive. So that's number one. Two, if you're at other risks, such as your blood pressure being high, get your blood pressure checked, and maybe at that time you may need other medication to manage your blood pressure at this time. It's also important that we don't forget to treat the sleep apnea. So limiting alcohol, sleeping on your side, a mandibular advancement splint, other measures may be appropriate to actually treat your sleep apnea at this time while not using CPAP. The other option may be a positional device to keep you off your back if you have sleep apnea more when you're lying on your back. And
I think, like as you said earlier, if patients in particular want to get guidance on what they need to do in that instance, then talking to their doctor is probably the first point of call and getting some advice. If they think if they're quarantining or suspected case, I think that's probably even more important.
I think that's exactly right. I think do check with your doctor if you're not sure. If you're in the very severe group, the risk of actually stopping CPAP may be greater than the risk of not stopping CPAP. So it's important, if you've got very bad sleep apnea, that you talk to your doctor before you stop CPAP, because the risks to you may be higher by actually stopping CPAP.
Okay. And you briefly mentioned, potential alternatives to treatment, and a lot of the people following the podcast are dentists prescribing oral appliances. What do we need to consider for patients that are on MADs, and what implications does the virus have on these patients?
I think if you've got a mandibular advancement splint, it's not going to change your risk to your partner, because there's no increased aerosolization of the viral particles. So I think that the risk is no different than if you're not wearing a mandibular advancement splint or you don't have sleep apnea. So I don't think there's any other major things we'd be recommending. I'd still recommend that people wear their mandibular advancement splints. There doesn't seem to be an increased risk to a partner by wearing a mandibular advancement splint at this time. So keeping your sleep apnea under control is important.
Okay, that's good advice, and I think will be reassuring for a lot of people. So my last question for you before we get into the presentation, if someone has suspected OSA, would now be a good time to be tested?
Yes, well, I suppose my feeling is yes, it would be. As lots of people are at home and not doing very much. So now might be a very easy time for people to actually have the test done. The equipment itself is cleaned thoroughly in between cases, and the nasal prongs are disposable. So yes, depending what equipment that are used, and making sure obviously that it's cleaned appropriate between testing, now would be a good time to get tested. Then it becomes what you do with those test results, and that will depend on severity of sleep apnea and what treatment is appropriate for you at this time.
Okay, fantastic. Well, thanks very much for answering my questions. I'm going to hand it over to you now, and we'll hear from you about obstructive sleep apnea and an approach to diagnosis.
Hi, my name's Linda Schachter, and I'm going to talk today about obstructive sleep apnea and an approach to diagnosis. First of all, let's talk about the terminology. Apnea actually means without breath, and the definition of an apnea is a cessation of airflow for greater than 10 seconds. A hypopnea is a reduction of more than 50% in airflow for more than 10 seconds and usually is associated with an oxygen desaturation of 2 to 3%, depending on whose definition you use. We also talk about RERAs, which is a respiratory-related arousal. An apnea-hypopnea index is the average number of apneas and hypopneas per hour of sleep. We also talk about a respiratory disturbance index, and that is the average number of respiratory events per hour of sleep. Now that's the average number of apneas, hypopneas, and RERAs per hour of sleep. Upper airways resistance syndrome is a condition where there is a predominance of RERAs or respiratory-related arousals or subcriterion respiratory events. An arousal is a transient awakening from sleep, and usually what that is an increase in EEG activity for 3 seconds. Hypoventilation is shallow breathing during sleep associated with an increased carbon dioxide level and usually with low baseline oxygen levels. Hypersomnolence is increased sleepiness. So today we're going to talk about obstructive sleep apnea. What is it? It's repetitive pauses or reductions in breathing during sleep. It's usually due to collapse of the upper airway, reduction in muscle tone during sleep, and there may be excess tissue in the upper airway or anatomical abnormalities which predispose the person to it. It's usually accompanied by reduction in blood oxygen levels and followed by an awakening or arousal to breathe. Multiple events overnight usually result in unrefreshing sleep and daytime tiredness or fatigue. It is a common chronic disorder that requires lifelong care. The mechanisms of sleep apnea, first of all, you fall asleep. Secondary, there's reduced muscle tone of the upper airway. And as you can see here on the left side of this slide, you can see here that the upper airway partially or completely obstructs. So pharyngeal narrowing, that causes an increase in negative pressure in the thorax or negative intrathoracic pressure. And as that mounts, it causes an arousal and then the person reestablishes their breathing again. So they wake up. In response to the waking, you get sleep disruption, a surge in blood pressure, and then muscle tone is increased, reversal of obstruction, and the person falls back to sleep. The sleep disruption can then result in increased sleepiness, reduced quality of life, and increased risk of car accidents or workplace accidents. The blood pressure surge increases the risk of stroke, heart attack, and it may also increase the risk of cardiac arrhythmias. So if we're looking at upper airway closure, we start with simple snoring. As the upper airway partially or completely obstructs further, we get these respiratory-related arousals or RERAs, and multiple of these will cause upper airways resistance syndrome. As the airway becomes more obstructed, we see hypopneas, then apneas, and finally what we see is hypoventilation. This is actually a bronchoscopy during sleep, and as we can see that the upper airway is completely open on the top right of the slide, and as the person falls asleep, we can actually see increased narrowing, and on the bottom left of the slide, we see cylindrical collapse of the upper airway causing obstruction. So what are the risk factors for sleep apnea? Overweight or obese. It's more common in men and postmenopausal women, and as we get older, it's increased risk. Race, so it's more common in Asians, African Americans, and it does run in families. Alcohol will increase the risk of sleep apnea, and so will sedatives, particularly benzodiazepines, analgesics, and anesthetics. Smoking will also increase the risk of sleep apnea. Cardiac problems such as heart rhythm abnormalities, hypertension, heart failure, pulmonary hypertension, or stroke. Pregnancy will also increase the risk of sleep apnea. Other risk factors for sleep apnea: neuromuscular disorders, if you've got any weakness, particularly of the upper airway, such as stroke, head injury, quadriplegia, or cerebral palsy. Endocrine or metabolic disorders can also increase the risk. Type 2 diabetes, hypothyroidism, androgen therapy, metabolic syndrome, acromegaly, polycystic ovarian syndrome, menopause, and renal failure. Chronic lung disease will also increase the risk. If you have any upper airway obstruction or abnormality, that you will have an increased risk of sleep apnea as well. Increase with nasal obstruction, pharyngeal obstruction, craniofacial abnormalities, laryngeal obstruction, or even just big tonsils. Retrognathia will also increase your risk of sleep apnea. What are the symptoms? Most people snore. Now, probably about 95% of people with sleep apnea snore. The fact that somebody doesn't snore doesn't mean you don't have it, but it is a common symptom. If somebody ever sees you having an apnea or witnessed apneas, the likelihood of you having sleep apnea is around 99%. Choking or gasping during sleep, recurrent awakenings overnight. Nocturia is increased in people with sleep apnea, and that's due to the increased intrathoracic pressure causing a release of atrial natriuretic peptide, and that actually causes increased nocturia. Restless sleep, and sometimes even people complain of insomnia. Waking with a headache, and usually the headache settles within about 20 to 40 minutes after waking. And this is actually due to the carbon dioxide rising overnight, and then when you wake up in the morning, taking a few deep breaths and the carbon dioxide level going down. Sleep fragmentation, so these regular arousals overnight, tend to cause unrefreshing sleep, being tired or sleepy during the day. May cause impaired concentration, irritability, personality changes, and currently about 40% of impotence is thought to be related to sleep apnea. Alterations in vigilance, alertness, memory, and disturbances in general intellectual function. Also been shown to be associated with reduced motivation, reduced exercise tolerance, and breathlessness. Children also get sleep apnea. The symptoms in children are actually quite similar for most of the case. They tend to snore, have restless sleep, may be complaining of being tired or sleepy during the day. But children may present with aggression, behavioural problems, poor memory or concentration, and they may also present with either a lack of motivation or even hyperactivity. Nocturnal enuresis may be associated with sleep apnea. The signs associated with sleep apnea, now obesity, particularly central adiposity, so we got central obesity, and increased neck circumference may be associated with sleep apnea. But if you're looking at the upper airway itself, we may see decreased oropharyngeal dimensions, an edematous, inflamed soft palate or uvula, or you might even just see decreased pharyngeal dimensions, so a narrow upper airway. Person who's got nasal obstruction, maxillary hyperplasia, retrognathia may be associated with sleep apnea. And then the consequences of sleep apnea, such as hypertension or other cardiovascular consequences. So what are the effects of sleep disorder breathing? Decreased quality of life, decreased survival, impaired academic or occupational performance, accidents at work. Single vehicle car accidents are 7 times more likely that you've got sleep apnea. Disturbances of mood or social adjustment or medical complications. The other thing is inability to sleep with the partner, whether that's due to the actual snoring or whether it's the apneas as well, and choking episodes. If we're looking at the cardiovascular complications of sleep apnea, hypertension, particularly if people need 3 antihypertensive medications, the thought is studies have shown 95% of people on 3 antihypertensives will actually have unrecognised sleep apnea. 50% of people with atrial fibrillation are likely to have sleep apnea. So cardiac arrhythmias are more likely in sleep apnea. Myocardial infarction, pulmonary hypertension. One of the most common causes of that is now sleep apnea, left and right heart failure, stroke, and sudden death. If we have a look at this is a study that was done out of the Woolcock in Sydney, and this was where they did blood pressure monitoring with somebody who had sleep apnea. If we have a look at the lowest of these screens, you can see the airflow where there's either cessation or of airflow in between the deep breathing. And in response to that, we're seeing oxygen desaturation. If we look at the top part of the slide here with the changes in blood pressure, you can see huge swings in blood pressure. So from a systolic blood pressure that's ranging between about 80 and 160, 170, and diastolics ranging between about 40 and 110. So enormous swings in blood pressure in response to these apneas or hypopneas. The neurocognitive complications of sleep apnea, increased car accidents, increased occupational accidents, difficulty concentrating or performing new tasks, and decreased quality of life. The other complications, we're seeing impaired glucose tolerance and diabetes, gastroesophageal reflux. Sleep apnea is thought to be a systemic inflammatory state with increased inflammation, arterial stiffness, and increased risk of atherosclerosis. Abnormality of lipid profile and a decreased response to drug therapy. And intermittent nocturnal hypoxia may contribute to the development and severity of non-alcoholic fatty liver disease or NASH. We also see difficulty with anaesthesia, particularly airway maintenance and difficulty with extubation or waking post-anaesthetic. And that may be due to acute on chronic respiratory failure. And there is an increase in 2 to 3 times increase in all-cause mortality. So if we look at the prevalence of sleep apnea and some of these comorbidities, drug-resistant hypertension, 83%. Obesity, 77%. The other thing to recognise is in 23% of patients with sleep apnea, they're not obese. Congestive cardiac failure, 76%. People with atrial fibrillation, 49%. Type 2 diabetes, 48%. All hypertension, 37%. And coronary artery disease, 30%. If you had an apnea-hypopnea index of less than 20, so mild or moderate sleep apnea, the risk of sudden cardiac death was only 2% over 15 years. But if you had an increase, if you had an apnea-hypopnea index of greater than 20, the risk of sudden cardiac death was significantly higher. Also, the degree of desaturation seems to also be associated with sudden cardiac death. So who should we be testing for sleep apnea? People who are tired or sleepy. Patients whose partners complain of snoring, or if they notice that the person is stopping breathing or having witnessed apneas. Patients that have a known history of chronic heart failure, atrial fibrillation, uncontrolled daytime hypertension or nocturnal hypertension, or patients who are obese. and then people who actually work in critical areas and are tired or sleepy. How do we actually evaluate these patients? First of all, we ask. So a history about whether they snore, have witnessed apneas, if they're tired or sleepy during the day. There are some screening questionnaires, and we'll go through those in a moment. Physical examination, whether they've got a crowded oropharynx or anything that might be physically obstructing the upper airway. And then doing a sleep study or sleep screening test. Other tests, such as blood tests or looking at airway or muscle function, aren't particularly helpful in most cases. There's several screening questionnaires that are used to actually stratify people's risk. There's a stop bang questionnaire, and if we have a look at here, it asks about being snoring, being tired, if you've actually had apneas, are you hypertensive. BMI is actually a stratification of obesity, so body mass index, and that's actually your weight divided by your height in metres squared. Overweight is over 25 kilograms per metre squared. Obese is over 30, and moderate obesity is over a BMI of over 35. So you have moderate obesity. So B is your BMI over 35. Age, over 50 years old. Neck circumference, do you have a neck circumference greater than 40 centimetres? And there's a heightened risk in being male. Low risk is if you only answer yes to 0 to 2 questions. Intermediate risk, yes to 3 to 4 questions. And high risk of sleep apnea is yes over 5 to 8 questions. There's also an OSA 50 questionnaire, and this is actually if your score is over 5, then you're at high risk of sleep apnea, and less than 5, a lower risk of sleep apnea. Epworth Sleepiness Score actually, it doesn't give us a great risk for sleep apnea. It tells us about people being sleepy. Obviously, that's one of our concerns if people are doing high risk jobs or if they're driving and they're sleepy. So an Epworth Sleepiness Score may also be helpful. Oops, sorry about that. If we look at the Epworth, I'll just go back to here, an Epworth Sleepiness Score, 8 and under is considered normal, 8 to 12 mild sleepiness, 12 to 15 moderate sleepy, and over 15 severe sleepiness. The 8 to 10 is actually still in question, but it's still better to be precautionary if people are describing sleepiness. So what do we do to investigate these patients? We do a sleep test. Now, level 1 is considered an inpatient sleep study, and where we look at EEG, and that tells us about brainwaves and stages of sleep. Nasal pressure, oximetry, and respiratory effort tell us if the person is actually breathing and trying to breathe, which will help us differentiate between different types of sleep apnea. Now, obstructive sleep apnea is the most common cause in 95% of patients, but there is also central sleep apnea where there is no drive to breathe. Heart rate and ECG tells us if there's any arrhythmias during the night, and we're also looking at leg movements and body position, whether there's any increased risk. Often patients will get sleep apnea in the supine position or lying on their back before they get it in other positions. Level 2 are sleep studies done at home. So there's similar measurements to level 1, except for it's in a non-supervised environment. Level 3 studies, so it's monitoring of respiratory parameters and oximetry, and usually there's for more than 4 signals. And often that'll be nasal pressure, thoracic movement, oximetry, and usually there's a body position. ECG may or may not be present in some of the level 3 monitors. Level 4 is usually just oximetry and pulse rate. Level 3 and level 4 are actually sleep screening tests, not actually sleep studies, because they don't actually measure the stages of sleep that you're in. In most level 3 and level 4 studies, if the actual person shows sleep apnea, they've got it. If it's negative, then It may not be, it might be a false negative test, depending on whether the person slept, which position they were sleeping in, and what stages of sleep that they actually did have during the study. Then what do we look at in these studies? What we're looking at is the severity of sleep apnea or obstructive sleep apnea syndrome. And what we look at is the respiratory disturbance index. That's the average number of respiratory events, so apneas, hypopneas, and RERAs, or respiratory related arousals, per hour of sleep. The other things that help us with severity are also the degree of oxygen desaturation, how sleepy the person is, and the medical complications that they have from sleep apnea. Okay, and then we can go on to other talks that will explain on how to approach these patients once we've diagnosed them. Thank you.